So today we're going to talk about upper GI disorders, specifically gastritis, GERD or gastroesophageal reflux disease, and PUD or peptic ulcer disease. So I don't know, we've always got learning objectives. Remember, these are the things that we're going to highlight on throughout the presentation, so that way you have a framework for what you should be studying for the exam. So go back, take a look at these at the very end as you start to set up your notes, and make sure you compare them to the lesson plan, so that way you can be on the right track for studying for the final. So throughout this, keep these in mind. Remember, this is the basis for everything that we talk about when we're structuring the curriculum. It's also one of the ways that we are writing exam questions. So thinking about, okay, how would I picture a quality improvement project surrounding multiple patients who have developed peptic ulcer disease in a particular patient population. So for peptic ulcer disease, for example, in QI, one of the things that came out of a study done for intubated patients was that a lot of them developed stress ulcers. And so now patients are automatically ordered for peptic ulcer disease prophylaxis as part of their admission to an ICU if they're going to be intubated. And so the provider has to answer a question about what sort of medication they're going to order for the patient to prevent the development of a stress ulcer. So it's usually a PPI, proton pump inhibitor, and that came out of quality improvement. So a bunch of patients developed a problem, multiple RCAs, root cause analysis meetings were had. The problem turned out to be patients secrete additional stomach acid during times of incredible stress, like a trauma or an intubation. And so that project led to better patient outcomes by having them prophylactically ordered for medications like PPIs. So thinking about different situations that way when you're either thinking about the material or thinking about a test question. Of course, we've got our old friend, the ATI clinical judgment model. We're going to be using something similar today when we go through for gastritis. I've put together a clinical case study that we're going to work through together as part of the online module for this course. So we're going to start with a quick A&P review. Again, we're talking about upper GI, but that's going to cover everything from the oral cavity straight through to the entering of the small intestine. So when we talk about peptic ulcer disease, we're going to be talking about the duodenum, and that's as far down in the GI tract as we're going to go for this lecture. Later on, we're going to be talking about something called a vagotomy, which is a severing of the vagus nerve for patients who have hypersecretory disorders, so patients who secrete too much stomach acid. And so if you take a look here, you can see we can cut the vagus nerve, that's this big nerve here, and that will prevent further innervation, so all these nerves no longer would work, and that's going to prevent the stimulation of cells in these areas from secreting hydrochloric acid or stomach acid, which if your patient has an ulcer or has an erosion, we don't want additional stomach acid to be secreted. And if a patient fails all other treatments, that might be the only option. And so there is a line here, and then there's another line up here. And you'll notice this line also cuts off not only gastric innervation, but also down here in the duodenum. So for a patient with peptic ulcer disease where it's in the duodenum instead of in the stomach, it might make sense for the provider to cut up high. So this is just a friendly reminder of the innervation of the stomach, so the nerves of the stomach. Again, thinking about what the nerves of the stomach do. So even just seeing food causes a stimulation of the vagus nerve, which leads to gastric stimulation and release of stomach acid. Here, the gastric phase, we're swallowing food and the vagus nerve is going to be stimulated, and we're going to have more reflexes and see these positives. We're going to have more stomach acid. Remember, our acids are positively charged, they have hydrogen ions, and this is right from Hoffman. And then when we get into talking about gastritis and peptic ulcer disease, it's good to remember what the stomach actually looks like on the inside. And so here you can see the rouget. That's that nice kind of wrinkly appearance of the stomach wall. If you think of putting your hand in water, or you're sitting in a bathtub for a really long time and you get that like wrinkly skin on your fingers, that's what the inside of your stomach looks like. And what that does for the stomach is it increases the amount of surface area. Because remember, if it's something flat, you've just got that flat surface. But if it's wrinkled, there's all sorts of surface area that then exists for things like secretion of enzymes, secretion of acid, for digestion and breakdown, and if necessary for expansion. So thinking of times when you might have a distended stomach for overeating, those rouget just stretch out. The other things that are important for this lecture today are going to be up here, the LES, or the gastroesophageal sphincter, or the lower esophageal sphincter when we're talking about GERD or reflux. The pyloric sphincter, we're going to talk about a surgery related to the pyloric sphincter later on. And of course the duodenum here, the entrance to the small intestine. And then when we're talking about complications later on, we may talk about perforation or penetration through the muscle walls. And so remember, the stomach is surrounded by several layers of muscle, and then this serous coating here on the outside. And so if erosions eventually turn into ulcerations, it can actually eat through these layers. The acid will eat through the layers of the muscle, and that would eventually lead to spilling of the contents of the stomach out into the peritoneal cavity, leading to peritonitis. And so just remembering what the A&P of the stomach actually looks like. Here we've got the rouget blown up nice and big, so you can see what they actually look like when we're talking about the wrinkled surface of the stomach. And so you can see it's got all of this surface area. Here we're looking at what's called the histology of the stomach. So if you took those rouget and you cut them down so you can actually see what's going on inside, you can actually see, so here's those nice wrinkled linings at the top, and they have these things called gastric pits. And we covered this a little bit in GI Farm, but I also know it's been a hot minute since we've talked about them. So there's all sorts of different cells that are secreting mucus, they're secreting digestive enzymes, they're secreting acid, and so those cells are actually what line these gastric pits, and you can actually see those right along here. And then underneath the rouget is going to be your circulatory system, and then here's those 3 layers of muscles we talked about in the last slide. And then the serous lining here on the outside, and so you can see as the stomach lining gets damaged, erosion will occur, and then perforation. And this is how we end up with GI bleeding, is once that erosion and ulceration happens, it eats away all of this tissue, and right underneath the layers of the rouget is all of the vasculature. So our veins and our arteries and our lymph system all are very easy to expose if this lining becomes damaged, which you're going to see later on when we talk about some disorders. And so here are the types of cells found in those gastric pits. The mucus contains bicarbonate. When we get to ABGs, you're going to hopefully remember that bicarbonate is a base or an alkaline. And if you remember, those are, they act in opposite of acids. And so the mucus in your stomach actually protects it from the parietal cell secretions, which are acid. So the acid combines with the mucus and it just is neutral. So it doesn't actually damage the lining of the stomach to have the hydrochloric acid present. And the hydrochloric acid is used to break down all of the food inside your stomach. So we want to make sure that we're breaking down food and not breaking down the stomach muscle and tissue. So that's why those mucus cells, both the surface ones and the neck cells, are so important. And then if you look further down, you can see here we've got chief cells that secrete pepsinogen. Pepsinogen is going to break down break down pepsin or proteins, and pepsinogen eventually leads to pepsin, and it converts into an enzyme in an acidic environment. And so we need that hydrochloric acid not only to help break down the food, but to also help break down the proteins specifically. And so the first thing we're going to talk about is gastritis. I know we talked about this last week, last time, is the inflammation. So in this case, we're talking about inflammation of the gastro, or the stomach. And it's an acute or patchy localized inflammation of the stomach lining. So causes can be diet that's high in caffeine, processed foods with lots of sugar, corn, chocolate, certain types of wheat foods like bread, energy drinks or other caffeine stimulants, alcohol, aspirin or other NSAIDs, radiation, cytotoxic agents. So remember, those are going to be our chemotherapies can cause gastritis, corticosteroid use. Remember, breaking down of the skin that's really thin. The same thing's going to happen to that membrane inside the stomach. Poisons, of course. And then major stress. So things like shock, trauma, a major surgery, anything that's going to cause a decrease in blood flow. If you remember back to our heart failure lecture, there was that image that showed where the cardiac output goes to each part of the body. 21% of your cardiac output goes to the GI tract. And so if we have a drop in blood pressure, either the patient's blood pressure becomes low because of shock, or because of significant bleeding, or because of medications that cause the blood pressure to get low, that's going to decrease blood flow to the stomach and can cause irritation and inflammation. And so acute gastritis causes an internal thickening and a red mucous membrane. It can potentially cause necrosis. Remember that irritation is not a good thing, and it's going to allow for more stomach acid, and eventually can cause slough. So thinking about that kind of crust or yellow tissue that forms during an inflammatory response. You might have seen it on a wound in a patient on their skin. Well, this is happening now inside the body. Patients often, if they have acute gastritis, will complain of nausea, and if it's bad enough, remember that kind of inflamed, ugly looking skin from the previous slide. It can actually cause GI bleeding just from all that friable, that irritated tissue. So chronic gastritis is continual irritation of that lining. So instead of something acute like a trauma or an ingestion, it's something that's causing constant inflammation. This is actually really nice on the heels of our discussion about autoimmune and inflammatory disorders. So things like lupus, RA, H. pylori. Remember H. pylori from our farm lecture, that's that bacteria transmitted through saliva or vomit or feces or unclean food that shows, that causes gastritis. I'm going to turn off my pointer here. So remember, autoimmunity can become is the body attacking itself. And so it can also be from the body producing antibodies against the parietal cells. That's those cells that release pepsinogen, or it can be an autoimmune tag on the actual intrinsic factor. So intrinsic factor is what we need to convert vitamin B12 into red blood cells. And so if your patient has an autoimmune chronic gastritis, they will often show as anemic. So thinking about how that patient might present with anemia. And so inside the body during gastritis, whether it's acute or chronic, the stomach lining itself is damaged. And so hydrochloric acid, remember, it's a highly acidic, so the pH is very, very low, and that moves into the tissue. So it falls down into those gastric pits that we saw, and it decreases the pH of the cells, and enzymatic activity, things that should normally be happening like pepsinogen, is disrupted. And so instead of pepsinogen percolating up to the surface and sitting in the stomach and being converted into pepsin inside the kind of bulbous area of the stomach, it falls down, or there's more of it and there's more acid present, and instead of bubbling up, it actually eats down. So it's going to fall down towards those tissue layers and towards those muscles and blood vessels that we saw in that, or those very early slides. At that point, cell structures become disrupted, and that's when those small blood vessels are now exposed to acid. And anytime we expose very sensitive tissue to acid, it's going to eat away or wear away at it. And so initially it'll cause edema from irritation and can cause hemorrhage, and over time cause ulceration. Now, if this process is caused by NSAID use, because remember, NSAIDs are one of our risk factors for acute gastritis, or from aspirin, those medications are anti-inflammatory meds, right? And so that actually will inhibit the prostaglandins, and that's going to actually make our mucosal integrity worse or thinner. And so not only does the patient have damage, but actually taking more NSAIDs or aspirin because of the pain will actually make this worse. And so remember, we talked when we were talking about RA, NSAIDs being one of the huge treatments, but RA is also a risk factor for gastritis. And so it's really important that if a patient develops signs and symptoms of gastritis, that we tell the patient we need to come up with another treatment strategy to deal with their rheumatoid arthritis, because we don't want them to continue to take the NSAID because that will make their gastritis worse. So this was just a nice chart of putting together some of the signs and symptoms. So the patient's going to feel bloated. Of course, they're going to have abdominal pain. Remember, we looked at all that innervation, those nerves that go around the stomach from the vagus nerve. They may experience hiccups, contractions of those muscles that are being stimulated by acid, burning or gnawing feeling in the stomach between meals or at night. We're going to talk a little bit more about that when we talk about ulceration, indigestion, and then there's a couple things about blood, right? So there's black tarry stools or vomiting blood or coffee ground material. That coffee ground material is digested blood. So the patient's bleeding into their stomach. The blood is interacting with the HCl, the hydrochloric acid, and it makes it appear coffee ground-like, so kind of a brown, small microclots. And the patient may experience nausea or recurrent stomach upset. And of course, if they've got any sort of stomach problems, they're not going to really feel like eating. So our gold standard for this is going to be a biopsy done through an EGD, esophagogastroduodenoscopy. Feel free to call it EGD. Done down in the endoscopy suite. We can also do fecal occult blood testing. So if your patient had a change in stool consistency or stool color, it might be helpful to have a fecal occult blood test done. Now, there's going to be some limitations. We won't be able to tell where in the GI tract that it's occurring just by using this simple test. And if the patient's taking certain medications, this will come up positive. And so if the patient's got hemorrhoids, this is going to come up positive, but obviously that was a very different treatment than if your patient has gastritis. And so this is only one of the tools in our toolbox. And then urea breath testing is something used for patients who have H. pylori or are suspected to have H. pylori. And so a baseline test is performed. This is an exhalation test. So we're looking at the patient's CO2. And then a patient will drink a urea solution full of a specific carbon atom. And that carbon atom is tagged with a little bit of radioisotope. So that way when the patient processes it, if H. pylori is present, it will break it down, release that tagged carbon into the bloodstream, and that carbon is then exhaled out of the lungs once it crosses from the bloodstream into the lungs and the alveoli, and we can actually monitor that. And so the patient could be positive for this urea breath test, which indicates the patient has H. pylori. At the end of today's lecture, we're going to talk about some treatments that are specific to that, and it's going to be kind of a recap of what we discussed way back in pharm. So for patients with gastritis, we've got kind of a three-pronged approach. So of course we're going to do medication and pharm. There is a great chapter in ATI, chapter 51, that reviews the medications that would be used. And since we've already done GI pharm, I'm going to refer you over to, this is the Med-Surg chapter, chapter 51 on gastritis. Supportive care for spontaneous healing, because this isn't really something we're going to go in and be able to do much about, because remember, this is gastritis, it's diffuse inflammation. So the only way to stop the inflammation from continuing is to support healing. So we can't give an anti-inflammatory because those are going to inhibit prostaglandins. So what we can do is GI rest, which is outlined here. Eliminate all known irritants, so taking a look down below at that, caffeine, spicy foods, bland, small, frequent meals, and then making sure the patient stays well hydrated. And now we're going to get into that vagotomy. So remember, one of the things that causes this kind of continuous irritation is the release of stomach acid. And so that stomach acid is released by the vagus nerve being stimulated. So in order to stop the vagus nerve from being stimulated, we would have to make the patient blind and not able to smell. And since we can't do that, instead what we'll do is we'll actually cut the vagus nerve. And so this is a laparoscopic procedure that's done, and it can be done specifically for gastritis, so the stomach only, and that's where that small incision is made right over the stomach, and we're going to cut down here at the bottom part of the esophagus. Or if there are problems with gastritis that continue down into the duodenum, then a higher cut is made. So this will prevent stimulation of stomach acid from the vagus nerve. The body will still continue to produce it, but it won't do it with vagus stimulation. And vagus stimulation is that sight and that smell of food stimulating the vagus nerve. So instead, it will just be when food is present that HCl will be produced. We can also do something called a gastrectomy, where parts of the stomach are removed, and this is used for chronic gastritis. And so parts of the stomach are removed and the remaining pieces are sewn together. And so it might be something like this small wedge. So we would cut out this gray area, and then these two black lines would be sewn together. And then it can be as dramatic as something as small as wedge, or as dramatic as a total gastrectomy where the whole stomach is removed. This is usually more for gastric cancer, which we are not discussing today, but you might see something like a wedge or a central gastrectomy. And so the patient will have parts of the stomach that are constantly inflamed and potentially ulcerated, removed, and then sewn back together. And then the other option is something called a pyloroplasty. So if this increase in stomach acid is because there is delayed gastric emptying, then what we can do is actually enlarge the size of the pylorus. That's the end of the stomach here that leads to the duodenum. And so here you can see pre-op, it's either got scar tissue built up, perhaps there was an injury here, perhaps there's been repeated ulceration that's led to scar tissue. And so what happens is this muscle builds up over time. And so laparoscopically, we can go in. We can also do it, I believe, endoscopy, and kind of open up this lining, stretch it using a dilator, or cut back some of this scar tissue. And that allows for more, for the gastric emptying to occur more easily, because now we have a much wider tunnel for food to pass through than we did before. So I put together a little exercise here for us to kind of work through the different parts of a gastritis case. So a 26-year-old female patient comes to their primary care physician's office with several days of nausea, vomiting, and abdominal pain. The patient states that she has been in her usual state of health up until 3 days ago when her symptoms began. So right away, you should be thinking, okay, this is an acute problem, right? Because the patient has not had symptoms up until the last 3 days. And so rather than thinking of a chronic problem, now we have something acute. So what sort of assessments would you like to make for this patient, since all we know is that they're a 26-year-old female with 3 days of nausea and had been in their usual state of health? So think about some subjective assessments that might be helpful for you to discern what's going on, what's causing the nausea for this patient and the abdominal pain for this patient, and then some objective assessments that are going to give you some additional information. So I'll give you a second just to write this down, kind of brainstorm some ideas. And you can pause this if you want a little bit more time. But some more information. Subjectively, patient states they are 6 out of 10 pain. Patient states nausea is worse when hungry. Patient states that she has noticed darkened color to her stool, dark brown and not black. Patient states she has not wanted to eat or drink for several days due to discomfort. Some objective information for you. The patient's temperature is 37 degrees Celsius. Heart rate is 125, blood pressure 102 over 82, respiratory rate is 20, and her SpO2 is 98% on room air. Whomever was caring for this patient was nice enough to do a set of orthostatic vitals. So laying down, the patient's blood pressure was 102 over 82, sitting 92 over 70, and standing 84 over 60. Their head-to-toe assessment, your patient is pink, warm, and dry. Mucous membranes appear slightly tacky. The abdomen is soft, round, and non-distended. Patient flinches to the touch when palpation over the left lower quadrant. And then some labs were also drawn. So sodium is 150, potassium 4.2, BUN 28, creatinine 1.0, and blood sugar 70. Patient has a white count of 9,100. Hemoglobin and hematocrit are 9.1 and 36, and platelets are 328. Patient also had a urine done. The urine was dark yellow with a specific gravity of 1.021, and a urine pregnancy test was negative. So taking a look at this information, try to think about what is going on with this patient. Why is this patient having pain, do you think? Why is the color of the stool important? What further testing might you do with that information? What about her labs? Are there things that are normal versus abnormal? And what sort of things do you think are causing that? Does your patient have an infection? What's their white count? Does your patient have a diabetic issue? What's their glucose? Does your patient have kidney problems? If they have a kidney problem, is it typical for someone who's 26 years old to have a chronic kidney problem? And what other information from the labs might be helpful? So taking a look, my patient's sodium is elevated. BUN and creatinine are elevated. Their urine is dark yellow, and the specific gravity shows that it is a thicker urine. It's not as watery. And my patient has orthostatic hypotension. So I'm going to bet my patient is at least dehydrated. I don't know if they're bleeding or not yet. Their hemoglobin and hematocrit are low, but not critically low, but their platelets are okay. So even if they were bleeding, they can make a clot. And so these are all things that I'm starting to pull together from my assessment. So taking a look at all that assessment information, what sort of nursing diagnoses might you expect if we are thinking about the patient being dehydrated, if we're worried about orthostatic hypotension, if we're worried about bleeding? And so take a couple minutes or a couple seconds to just write down some potential nursing diagnoses. And you can write down more than one. And then when you're finished with that, I want you to circle the ones that are a priority. And so a priority nursing diagnosis isn't going to be a risk for it necessarily if there are actual problems for the patient. So while the patient should have potential risk for diagnoses, I want you to think about what actual problems this patient has, because that's going to kind of determine what we do next. And so if the patient is dehydrated, one of our nursing diagnoses might be fluid volume deficit related to vomiting and decreased PO intake, as evidenced by or as demonstrated by low blood pressure, high heart rate, right, our compensatory mechanisms, and then our concentrated urine. We could also add in our elevated BUN and creatinine and our elevated sodium. So if we've got fluid volume deficit, what sort of plan or what sort of things are you thinking you might need to do for your patient? So take a minute or two, go through, think about what your patient is going to need going forward. And again, you can pause this at any time if you need a little bit more time to write this down. So we're going to need to address the fluid volume deficit, address the abnormal vital signs. We want to continue to monitor vital signs to make sure the patient's vital signs are abnormal only because they're dehydrated. Remember that hemoglobin and hematocrit is kind of borderline. And so if the patient has further changes in their vital signs, I would be concerned that they're bleeding, so that gastritis has gotten to the point where the tissue is bleeding internally. They're going to need an EGD, right? We said that that's the gold standard. And then, of course, we're going to need some medication administration. And so that's where I am in the planning phase. And so my interventions should address all those issues. So address fluid volume status. What sort of interventions am I going to need to do? Address abnormal vital signs. What sort of interventions? Monitor vitals. What sort of order am I going to anticipate needing for an intervention there? If my patient's going to have an EGD, what sort of interventions am I going to need to be ready to do? Or what can I do to get the patient ready for that? So things like IV hydration, a proton pump inhibitor. So I don't want my patient to continue to excrete more acid if the patient's got gastritis or friable tissue. And so in this case, I would probably, if I'm giving IV hydration, also give an IV proton pump inhibitor. So since I'm in a primary care office, at this point, I'm going to probably ask that the patient be admitted to a med-surg floor. So either a direct admission, or I'm going to send them to the emergency department. And so now I'm moving into systems-based practice. I'm going from the primary care office to the either the directly into acute care or into the emergency department. And that patient, if they're going to get IV hydration, should probably also get IV, likely Protonix or pantoprazole, 40 milligrams IV, because I'm already going to have IV hydration. At this point, if the patient's going to go have an EGD, I want them to be NPO. So just giving them some oral fluids not going to be appropriate. Going to have them I'm going to expect, if I'm now moving into the inpatient setting, the patient's going to need regular vitals and orthostatics to make sure that our fluid hydration is adequate. NPO, I'm moving further into systems-based practice, thinking about endoscopy. If I know that I'm now moving into the acute care setting as a nurse, so taking a shift from now, I'm not in primary care, but now I'm in acute care, I might be checking for informed consent. If I'm the endoscopy nurse, I'm definitely checking for informed consent. If I'm the ER person or the acute care person, I'm placing a large bore IV so I can give fluids. And so that way the CRNA or anesthesiologist can give sedating medications through that large bore IV. If I'm in the primary care role or the endoscopy role or even the acute care role, I'm going to be teaching the patient what an EGD is. So what does that mean? What does it look like? What should the patient expect? And I might print out those consent forms. So that way when the provider comes and they discuss the procedure further, the consent forms are ready. I'm going to monitor the patient's eyes and nose, again, going back to thinking about that hydration. And I'm going to anticipate needing repeat labs, especially where we're concerned the patient might be bleeding. And so how am I going to evaluate all those interventions? What's my outcomes or my evaluation process for everything that was on that last slide? So go ahead and take a second, take a look at what you wrote. and then think about how you're going to evaluate each one of those. How do I know that what I did was effective in making my patient better? So my outcomes will be patient will have stabilized vital signs within 2 hours of IV hydration administration, so short-term goal. Patient will have an EGD scheduled within 1 hour of contacting. Now that doesn't mean the EGD will be within 1 hour. It just means that the scheduling will have occurred within 1 hour of me reaching out. Maybe I have to, as the nurse, reach out and leave a message. And so if I don't hear back, I want to reach back out and say, okay, I have this patient. When can I get them in? Patient will state the purpose, procedure, and expected outcomes of an EGD in their own words. So this is my patient being able to do return demonstration of education so that I know that it's not just me lecturing the patient. Remember, this is a stable patient, and so we should be able to spend a little extra time doing the teaching. Patient will experience relief from abdominal pain after 2 administrations of a PPI given IV push. So hopefully within 1, but realistically I want to make sure that it might take 2 administrations of that pantoprazole or Protonix. Patient will not experience orthostatic hypotension. So we didn't talk about risk for falls because it wasn't our priority diagnosis, but this would address not only the fluid volume status, but we want to make sure that the patient's risk for other issues is not getting worse. And so patient will sign informed consent after meeting with the GI team. Remember, our role as the nurses to facilitate that, but we don't actually obtain it necessarily. And then again, readdressing that hydration, patient will make at least 30 mLs of urine within 4 hours per hour, within 4 hours of IV hydration initiation. And so that's one way to go through as you're getting ready for the final, doing that sort of exercise with any of the disorders that we've covered throughout the semester, whether they're med-surg disorders, whether they're mental health disorders, taking a look at how the patient's progressing and taking a look at the different facets of nursing. What would I do if I was primary care? What would I do if I was emergency? What would I do if I was acute care? What would I do if I was procedural? Now that you've got that understanding, and that will help you generate a care plan using either ADPI or the clinical judgment tool, either one, so that we have a more thorough understanding. So now we're going to move on to GERD, so gastroesophageal reflux disease. It's a chronic GI issue caused by acid reflux in the esophagus. It might cause tissue damage, it might not, and is often caused by a weak LES, lower esophageal sphincter. And so here we can see stomach acid in the stomach backing up into the esophagus here, and this is the LES that's dysfunctional. Just a bigger picture so that you can actually see what the LES is. It's this ring of muscles that should stay closed so that stomach acid doesn't back up. But unfortunately, sometimes we're going to see a whole host of risk factors. This muscle can become weakened or can be eroded and no longer works, and that allows stomach acid to go up into the esophagus. And so normally the esophagus is coated in saliva, which is high in bicarbonate. Remember, bicarbonate is an alkaline or a basic fluid. So it is going to, when it meets acid, neutralize it. So that way the acid doesn't erode anything. But unfortunately, with all of this stomach acid eroding up, the body is not able to keep up with mucus secretion or swallowed saliva. And so acid will actually damage the inside of the esophagus here. Other things that are in the esophagus that help protect it are mucus, prostaglandins, and epithelial growth factor. And acid, when it comes into contact with all of that, will wear away those protective coatings. And eventually, once it wears away the protective coatings, will actually wear away the lining of the esophagus. So obesity, so things that will stretch out the abdomen, will cause a weakened LES. So obesity, it might be distension of the stomach, and that can occur either via pregnancy, rapid weight gain, it might be ascites, things that are distending of the abdominal cavity. Distension of the stomach can also be large food boluses. So a patient who receives nutrition through an NG tube or a G tube and has bolus feedings would cause a distension of the actual stomach. Large meals. So maybe your patient only eats once a day, but eats very, very large meals. Or Thanksgiving, for example. a sedentary lifestyle, certain diet triggers, foods that are high in acid, caffeine, chocolate, and spicy foods. Those are going to be stimulating foods. They're going to stimulate additional hydrochloric acid production. So it's not just that those foods necessarily have high acid, although they can. It's that it stimulates the body to produce more acid. Tight clothing, something that's going to change the pressure of the stomach, might pop open the LES. The presence of an NG tube, because that's holding open that stomach muscle, that ring of muscle between the stomach and the esophagus. There's now a tube, literally a little straw, holding it open, and so there's room for acid to back up into the esophagus. And then delayed gastric emptying. So we talked a little bit about pyloroplasty earlier when we talked about gastritis, where that scar tissue has built up and caused delayed gastric emptying. But think about the new classes of diabetic management meds that are also being used for weight loss that are also causing delayed gastric emptying. And so if we're giving a patient a once-a-week injection, either for diabetes or for weight loss, that's causing delayed gastric emptying, that stomach is fuller longer. And so it causes distension, which can open the lower esophageal sphincter and allow acid to back up. And of course, our old friend, H. pylori, can also cause GERD. So clinical manifestations, patient's going to complain of heartburn, might be atypical chest pain or painful swallowing, so feeling that burning sensation in the esophagus. They're not going to complain of a hemorrhage, but we're going to see signs and symptoms of bleeding. The acid can actually vaporize and go up into the mouth, especially during sleep when if the patient's laying flat, and that can actually erode away the teeth and cause dental enamel and cause dental caries. Your patient, if it's also in the mouth, can then aspirate, breathe it in, which can then cause aspiration pneumonia. So that's that gastric acid, instead of going back down into the esophagus, actually getting diverted into the trachea and going down into the lungs, which causes aspiration pneumonia and a chronic cough. It can also irritate the vocal cords, again, getting up into the mouth. It can cause asthma. Of course, if it's an acid, it's going to cause irritation and inflammation. So we're going to see irritation and inflammation of the larynx, the pharynx, potentially bronchitis if it's down in the lungs, and then regurgitation or vomiting. So our way to diagnose it is a 24-hour pH monitor. I've got a video. If it doesn't appear in this presentation, I'll pop it in on Blackboard. And you're going to do a food diary and symptom tracking. An EGD, so we're going to be looking for esophagitis if there's strictures present. So remember, acid is coming up and eating away the tissue, and so what's going to happen is scar tissue is going to start to form. And scar tissue is not stretchy the way the natural tissues of the esophagus are, and so it will get tighter and tighter and can actually prevent food from passing into the esophagus, from the esophagus into the stomach. And so that's called a stricture. And then Barrett's esophagus, and I've got some pictures of that, and that's that columnar cells that develop from repeated exposure to acid. And if you remember from pharmacology, that's a precursor to esophageal cancer. And then esophageal manometry is measuring the pressure inside the esophagus, and that's really the gold standard for understanding activity inside the esophagus. So our treatment or therapy, we want to decrease acid secretion, increase stomach emptying, and so there are medications for both of those. So for our acid secretion, PPIs and a H2 receptor antagonist. Increase stomach emptying, prokinetics. We're going to increase activity, increase kinetic activity. We're going to give medications to protect the lining of the stomach. So you can see the list there. And then some lifestyle changes. So we're going to avoid eating chocolate, nitrates, remember things that are going to cause dilation. Citrus will actually decrease the LES pressure. We want to avoid caffeine, because remember that's going to be a stimulant for acid. We're going to avoid tight-fitting clothes, especially around the abdomen. And then elevating the head of the bed. If your patient has one of those fancy mobile beds, you can have them elevate up to 30 degrees, or they can use blocks, even something like a brick, to elevate the head of the bed 6 to 8 inches. And that's going to help keep the stomach acid in the stomach, rather than when the patient lays flat, allowing it to go up into the esophagus. Unfortunately, if the patient is refractory, meaning non-responsive, to those other issues, or if your patient has a hiatal hernia, we can actually do what's called a Nissen fundoplication. And so here we can see the top of the stomach is actually wrapped around the esophagus. So here's the esophagus. And we're going to wrap the stomach around it and then suture it closed. And it's going to create a second stricture, or a second way for a pocket to close the esophagus and help prevent acid from traveling back up. We can also do something called stretta. And so this is done through endoscopy, and radiofrequency energy is done, and it actually helps decrease COX activity. Remember, COX-2 inhibiting, going back to pharm and anti-inflammatories, and it helps promote healing. And so this would be a patient needing this to be done through endoscopy. This can be done through laparoscopic means. Both of them are only done if the patient doesn't respond to other therapies first. Here is a picture of Barrett's esophagus. And so here's a nice normal esophagus. You can see this kind of white lining. This is all scar tissue that's building up. This is just the endoscope here, but these are all areas where scarring has happened from GERD. So again, a nice picture that kind of helps summarize everything we've talked about. So how your patient's going to feel, things that are a risk factor, and then things that are going to aggravate GERD. So just kind of a nice one-pager of a summary. Next, we're going to talk about peptic ulcer disease. So an ulcer is a break in the lining of the mucosa with depth. So it doesn't mean it's just a superficial erosion. Erosion means no depth. This is actually meaning it's going through the initial tissue layers as ulceration. And so here, the culprit is pepsin. So remember, we talked about those cells that release pepsinogen, and in a highly acid environment, that pepsinogen is converted into pepsin. And pepsin is great when we're eating high-protein meals, but when it's kept down in those gastric pits, when it's converted into pepsin from pepsinogen, and it starts to digest proteins, the only proteins available is the stomach itself. And so it will actually start to digest the stomach. So 80% of the ulcers are in the duodenum. Unfortunately, they're very common here in the US, but fortunately, deaths are very rare. And so, well, we have plenty of patients who have duodenal ulcers or gastric ulcers. That fortunately, we usually are able to catch the clinical manifestations before they become fatal. Things that do cause long-term problems are things like hemorrhage, abdominal or intestinal infarction, perforation or penetration that can lead to peritonitis and sepsis. And so here we have a look at the stomach. We can see where there are ulcers, and this is what I mean by erosion. And so here's those rougeae, and erosion is right here superficially. So this is what we see when we see gastritis. This is erosion and irritation. Ulceration means we're down in the muscle layer. So remember, all the way back to the beginning, we looked at that A and P of the stomach. We've now gone through all the gastric pits. Through here, we can see a little vein and a little artery, and now we're down into those 3 layers of muscle that are wrapping around the stomach. And then a perforating ulcer means we're through all 3 layers and into the serosa. So that's that thick membrane that surrounds the outside of the stomach. And if the erosion happens through the serosa, then we've got leakage of the stomach all the way into the peritoneal cavity. So an acute issue is going to be into those 3 layers that wrap around, go back to the beginning if you can't quite remember, the layers of the stomach. And then So acute is somewhere in there where penetrating or perforating is all the way through. And so this is really incredibly dangerous for the patient. And this is where our fatal issues happen. I'm hoping this video will play. Again, if not, I will make sure I upload it. But this is just a quick video of an endoscopy. Doesn't look like it plays in this mode, so I'll make sure I upload a link to this into Blackboard so that you can just see what an endoscopy is. If you're not familiar with one, it's really helpful in visualizing ulcers and areas of erosion. Oh, for goodness sakes, every time, right, guys? So I'll make sure I upload this into Blackboard or link to it. So some causes. Of ulcers, NSAID use, remember that's going to cause that gastric irritation or that gastritis, gastric irritants, things that are going to increase the secretion of acid, trauma, major stressors, which we talked about already in gastritis, alcohol use, and smoking. And of course, our friend H. pylori, because again, that's chronic inflammation, and H. pylori will actually proliferate when there is more acid present. So our clinical manifestations, it depends on where the ulcer is, and it's incredibly important that we rule out other causes of chest pain or GI pain before we determine that it is necessarily an ulcer. And so if your patient's complaining of atypical chest pain, we still want to make sure, especially if they're female, that they're not having an MI. But if it's gastric, there's going to be pain in and around eating without relief. Whereas if it's duodenal, the pain will actually be relieved by eating. And so that's the really important difference between the two and helps us determine what's going on with the patient. So our treatment, of course, we're going to want to decrease pain first. Now remember, we can't use NSAIDs. So in this case, we want to treat what's causing the pain. We want to promote ulcer healing. And of course, we want to prevent the recurrence and decrease our complications. So decreasing our pain might be giving something like a PPI or an histamine 2 receptor antagonist. If we know what's causing the ulcer, so whether it's, diet, or it might be NSAIDs, or it might be H. pylori, making sure we're doing what we need to promote healing and prevent whatever that issue is from happening again, and then teaching the patient about signs and symptoms of complications if we're not in a place where we're going to be monitoring them frequently. To control H. pylori, you're going to give a combination of antibiotics, and these are the common ones that you're going to give, and we're giving 2 or 3 of these at the same time, and an H2 receptor antagonist. So famotidine can be given IV, cimetidine is given PO. So we're going to be giving 2 or 3 antibiotics and an H2 receptor antagonist. So thinking about what complications we could have from giving several antibiotics at the same time. So making sure that we're teaching the patient about C. diff. When we're giving multiple antibiotics plus an H2 receptor, we can also be worried about electrolyte issues. Making sure that if it's a particular medication that might cause complications with birth control, that we're educating the patient about that. So really being aware of the potential adverse effects of giving these antibiotics. And the antibiotic regimen is usually given for 14 days. If we're not able to resolve the ulcer with multiple antibiotic regimens and lifestyle changes, unfortunately, the patient might require surgery. And so we already looked at gastrectomies and vagotomies, but they can actually oversew the ulcer, and I'm going to show you some images of what that looks like here. So here you can actually see this is an ulcer of the stomach. This is actually the stomach lining that's all inflamed. You can see it's got a little hole in it, and so laparoscopically they will go in. This is 2 pairs of tools that go in laparoscopically. Here you can actually see the cord that they're going to use to sew the ulcer closed, and so here we can see them closing with multiple stitches. This is the first stitch, and now we've got multiple stitches closing up that hole. Now you'll notice this is a wire mesh. So thinking about future considerations, what does my patient need to be aware of if they're going to have an MRI? that they've got this wire inside. And so being aware of that as the nurse for patient education down the road. Post-op, your patient is at risk for something called dumping syndrome. So fluid shifts in the abdomen after rapid gastric emptying or a high carb consumption. And so taking a look, if it's within 30 minutes of eating, your patient is going to experience nausea, vomiting, sweating, dizziness, tachycardia, heart palpitations. If it's later, it is excessive insulin release. So go back to thinking about hypoglycemia from our diabetes lecture at the start of the spring. So dizziness and sweating, tachycardia, that shaky, that feeling of anxiety, your blood sugar is too low. And this is right from ATI. Gastric outlet obstruction, also from ATI on page 69. That's from usually in the pyloric area where there's been scarring and stenosis. And so the patient now can't vomit, can't digest food. It doesn't pass from the stomach into the small intestine. So your patient will feel nauseous, they might feel distended, and if they vomit, it'll be undigested food. So we want to avoid gastric irritants. I feel like we have been saying this over and over again. Small frequent meals, make sure they have adequate fluid intake. We really want to protect that stomach lining. Some complications, hemorrhage, of course, we talked about bleeding already. Abdominal or intestinal infarction, so where the stomach muscle is dying off because of inadequate blood flow, or intestinal muscle is dying off because of inadequate blood flow. The ulceration has eaten through the vein and the artery. The patient is bleeding into their stomach, and there's no blood flow going to the muscles because the blood is being diverted into the stomach through a hole. Perforation and penetration, which we spoke about a little bit earlier when we showed those layers of the muscles. Gastric outlet obstruction from scar tissue building up over time after repeated ulceration. And then peritonitis, again, if that perforation happens through the serosa of the stomach. And then because we're going to be, if we've got ulcers, constantly regenerating cells in the presence of acid, it does put the patient at risk, increased risk for adenocarcinoma. So some sort of adenocarcinoma inside the stomach. Because remember, adenocarcinoma is secreting cells, and our secreting cells in the stomach are being damaged by acid. And so we have a risk for cancer inside the stomach that way. This is a video on the Mallory-Weiss tear, which is a complication from peptic ulcer disease. I'm going to see if the video plays. If not, again, I'll pop it up. It doesn't look like it's going to. But, oh, you're perfect. Here we go. Let's see if I can get it to play. Fabulous. I'm just going to jump ahead a little bit here. Maybe. All right, I'm going to see if I can get it to. All right, so I am going to try and jump ahead just a little bit here. Let's see. Guess not. All right, and then finally, we're back to our closure.